54-year-old male. Incidental aneurysms during investigation for headache. Neuro examination normal. This is his angiography. Here on the left side we have the right internal carotid artery AP view. And we can see here this is A1 and there's an aneurysm located here. On the right we have the lateral view of the same angiography. Here's the carotid artery, ophthalmic artery. We can see that the aneurysm is pointing forward. So it's pointing anteriorly in surgery, the aneurysm will be pointing upwards. And we can tell that there's one A2, one is located behind, and one is located forward in relation to the aneurysm. This is the 3D reconstruction of the angiography. And here this is A1, and then A2, A2, and the aneurysm is right in the middle. Let's go to the video. This patient underwent right Theriona approach. So this is the right frontal lobe, right temporal lobe. He's dissecting the superficial part of the sylvian fissure. Using sharp dissection, mainly knife and scissors. Now gently, slowly. We've seen this many times during this chapter. So cutting the arachnoid, retracting with the suction tube. You can follow small arteries. Small arteries will always lead you to the sylvian fissure, to larger arteries. And then retraction is in the depth, but exposing this arachnoid, so for you to cut. Now this is a bridging vein crossing from the temporal side to the frontal side. You have to coagulate and then cut. And then now there's always a vein crossing, running from the frontal orbital area to the temporal side, draining to the sphenoparietal sinus. So he's coagulating this vein and cut. This is the right optic nerve, right ICA. Now he's separating the frontal lobe from the right optic nerve. This is the left optic nerve. Cutting arachnoid membrane. Now we have a better view of the left optic nerve. This is the region of the lamina terminalis. This is olfactory tract. This is rectus gyrus. And now he's opening the interhemispheric fissure. By doing this, it will be much easier to retract the rectus gyrus. Now rectus gyrus under the spatula. And this is A2 from the right side. This is the A1, right A1. Now he's dissecting. The aneurysm is pointing anteriorly on the angiogram, so it will be pointing superiorly here in surgery. Now this is left A1. Now he's clipping the aneurysm. The left A2 is down here. He's using a curve clip. Now he's checking, repositioning the clip. going deeper with the tip. Adjusting once again the clip. Now, probably part of the neck is still there. Adjusting again, trying to occlude completely the neck of the aneurysm. Okay, that's a A2. So still neck left over there, here. Still neck over here. It's puncturing. He thought otherwise. He thought that the aneurysm has been completely occluded, but it's not, so it's still bleeding. Now he's coagulating to shrink the aneurysm. So very gentle coagulation. You cannot squeeze too strongly the aneurysm. Gently squeeze the aneurysm. And then he's releasing the clip. It's not bleeding anymore. So it's going to get another view of the neck of the aneurysm here. You can see this is left A2, right A2. Now it's a semi-curve. It's less curved clip than the previous one. And now I think the aneurysm has been completely clipped. Now puncturing the aneurysm, so it's not bleeding anymore. Coagulating once again the aneurysm. And cutting the aneurysm. The aneurysm has been completely opened. Now he's trying to separate the aneurysm sac from the left A2. This is left A2. Now the aneurysm sac is left here. So this is a final aspect after the clipping of the aneurysm of the ACom. And this patient has another aneurysm located at the anterior choroidal artery. Anterior choroidal artery. See the aneurysm? He has to clip, and this is the anterior choroidal artery. So you cannot clip the anterior choroidal artery, just the aneurysm. This is kind of tricky. Very small clip. So this is the anterior choroidal artery. Trying to preserve it. Now the small aneurysm has been clipped. Now he's checking. That's the artery is there. It's not included in the clip. The patient remained neurologically intact after the surgery.